Okay, so as a lot of you know, we've been charged by your chairman, Reed Pavin, to do the Basic and Clinical Science series Retina book over the course of a couple of years. So this talk is a chapter from your Basic and Clinical Science series board book. Those books, I read those books 3 times during residency in preparation for the boards, and it worked. You know, I passed the boards, the written boards, easily after reading those books and taking notes on them and just repeating it, because the entire written boards are based on your Basic and Clinical Science series books. They can't ask you topics that are not in those books. And they're kind of dry, but that's how you do well on your OCAPs. And Herschel, how important are your OCAPs when you're looking for fellowships?
It depends on where. It hasn't really come up too much. A couple programs will ask, even though they're not supposed to. You know, I didn't get an interview at Vanderbilt probably because of my OCAPs.
Do you send them in? Do they request that you send in the OCAPs these
They do.
days?
They do.
So they're at least asking for them.
At least 5 or 6 that I applied to probably did.
But you read all 13 books 3 times?
Yeah.
And
That's what
I was a fellow, I was a resident from 03 to 05, so I didn't have an iPhone or a BlackBerry. I didn't have anything to do but read the books.
And there was no opto
You know,
questions.
There was
Were you single?
I was single. I did 1 or 2 other things other than read the books, which is true. But I did read the books a lot. In the first year class, are you guys single or married?
Married with a 6 month.
6-month-old? You got a lot of time to read the books. Single or married? 6 years. Single?
He's a medical student.
Medical student?
Okay.
All 4, the rest are single.
Single. Okay, good. So you guys have plenty of time to read the book. Nothing else to do. Okay. So this is a book on the diseases of the vitreous and the vitreoretinal. This is a chapter on diseases of the vitreous and vitreoretinal interface. I'm going to start it with a quick story. I was a fellow, and in part of my fellowship, we had to operate in a big ancient hospital every Friday on the 6-month rotation. I did twice. Every Friday we'd be in the big ancient hospital operating, and when you're in a big ancient hospital, our turnover time's slow or fast at Tampa General. Slow, so slow. So you sit in the doctor's lounge a lot. So I'm sitting in the doctor's lounge as a fellow, as a first-year fellow in the big ancient hospital, you know, waiting for like my second case, which is starting at like noon after the first one started at 7. And there's a general surgeon, a very famous general surgeon who's very talkative. He was an older guy, and he says, "Doctor, I see you're a fellow. What's your fellowship?" I said, "I'm an ophthalmologist. I'm a fellow in vitreoretinal surgery." He goes, "Oh, you're a vitreoretinal surgeon." He goes, "What is your procedure?" "My procedure is the appendectomy." "What is your procedure?" I go, "Well, my procedure," I was feeling very fancy because this guy's doing appendixes. "My procedure is the vitrectomy." You know, he's like, "Well, tell me about that." You know, so I tell him about vitrectomy. Probably knows about this. He's done this before, I think, in retrospect. But so I tell him I do vitrectomy and take out the vitreous, and then we have these trocars that are new, and we have this 20 gauge thing, and we have these cutters, and we have all this stuff that we use to do things to the retina after vitrectomy. He goes, "So you're a vitrectomist?" And I said, "Yes." He said, "That's interesting because you are an expert in an organ that doesn't exist, the vitreous." And that was it. That was him making fun of me in my fellowship, which I actually thought was very funny and offensive at the same time. And the reason I picked this chapter is because that was a very impactful conversation to me, because the vitreous is very real and very much does exist, and it causes a whole bunch of problems. It is my surgery. It is what your vitreoretinal surgery begins and sometimes ends with, is working with the vitreous. Another famous attending in my fellowship was a retinal surgeon, said, "Do as little to the retina as you possibly can to have a good chance of anatomic success. Do it all to the vitreous and leave the retina alone." And I think he's right. I think of that a lot when I'm doing things to eyes. Don't do stuff to the retina. Okay, so posterior vitreous detachment was discussed by Dr. Cohen last week. I'm not going to rehash that. It's very common. The vast majority of us, if we survive to be 80, will have vitreous detachment. Flashes, floaters, those are symptoms that should be evaluated because there's a risk of retinal tear. And Dr. Cohen, in his lecture on retinal detachment and tear, went over all of the aspects of vitreous detachment which have risk. So epiretinal membranes are the first thing we're going to talk about. They're very common. They're a very high incidence. If you look at the epidemiology of them, about 2% of patients over age 50 have them, and 20% over age 75 had them, and in about a fifth of all patients, they can be in both eyes. of varying symmetry. They're often asymptomatic, but they can cause macular symptoms of central blur and central distortion, and they're semi-translucent, they're reflective. There's only one procedure that works for them, which is vitrectomy, so your options are easy. It's observation or vitrectomy. And you see a whole bunch of them after things are done to the retina, like retinal tear and detachment repair, or diabetic retinopathy that requires treatment, or vein occlusions. Most of those that follow pathology are not visually significant. Okay, we're going to do a lot of pictures in this talk, because I think pictures and cases are impactful and they're good teaching points. Case 1, it's better to peel too little than peel too much. This is a 69-year-old pseudophakic male with a pucker for 7 years. He gets referred to me from a good referral source who has this person as his administrator for like 20 or 25 years. And this person's retiring. As a retirement present, he's referring this patient to me for a pucker peel. This guy's turned down pucker peels from other people in the community, but he decides he wants to have me do his retirement pucker peel. So I peel him. He goes from 2100 to 2032. He's very, very happy. And here's what his macula looks like. Here's right macula, 2100 at presentation, pucker for 7 years. I tell him how it's unlikely to, have a lot of improvement. It's been there for a long time, but if he really wants it, I'll give him his retirement pucker peel. I do this. I peel too little. I don't get the whole thing. But he's 20/32. You can see his fovea is intact. He's thrilled. He doesn't care that the OCT looks like there's a little bit of pucker left. Foveal traction release is important. It's very important to not peel too much. If you peel too much, you'll see what happens here. This is a 68-year-old male who was referred into our practice following pucker peel by another retinal specialist in the community. And he presents as hand motion before my partner, Dr. Cohen, puts him back together to 7/200. This is what the macula looks like when you peel too much macular pucker. And this actually happens more often than you would think. You would think you would see all sorts of hemorrhage and trouble intraoperatively and stop, but people don't stop. They peel the entire macula sometimes. So this guy came in hand motion, Dr. Cohen put him back together to be 7/200. You can see the enormous macular defect where what may have once been a pucker and certainly was a fovea and a macula used to be. But he's attached under oil and is still very unhappy that he had his macular pucker peel.
Can you get back to that photo real quick?
Mm-hmm.
So what are we looking at here? It's like there's a peripheral RD, but then what's the orange thing in the middle?
Is it supposed to? No, that's a huge macular hole. That's an iatrogenic macular hole where somebody peeled the macula out of the eye intraoperatively
So
a couple of months before this.
The membrane is the macula.
That's right. Someone read the little forceps. Your little forceps. They go like that, and they will pick up the whole retina. In fact they will go into your choroid if you really go for it. So instead of peeling the macular pucker like in this prior case where I peeled too little, the thickness of that membrane is about 20 microns. So you hardly have to touch it to peel. So you peel too little with those forceps, but the forceps, they have a lot of grabbing force. They are measured in grams of grabbing force, and the disposable forceps are actually really good at grabbing. So if you go too deep and you peel too much and you don't stop, you can peel the entire retina and the membrane if there was a membrane there and the fovea. And that's what you're seeing in that orange circle there. That's an absence of retina. You're looking at bare RPE and a big detachment associated with that iatrogenic macular hole.
So post-operative color on this photo would just look normal after a membrane peel?
Not exactly, but it looks much better than this.
Okay.
This is another example. We've had a couple of examples of macular disaster today. This is one of the types of macular disaster. Good. So here it is. I just put back together. This is a color fundus photo of that macular hole put back together by Dr. Cohen with oil in the eye and a retinal reattachment, a visual acuity of 7/200. So peel too little, don't peel too much. Case 3, anatomical success. Does that equal visual success? Here's a 68-year-old female who's pseudophakic, who had a beautiful retinal detachment repair, and she was 20/40 post-retinal detachment and goes down to 20/80, and she's progressively more and more unhappy. She gets her macular pucker peel, goes to 20/50 plus, and she's still really unhappy. She says, I cannot see. Here she is pre-op. There's her macular pucker, 20/80, following macula off retinal detachment repair. Here's a cut down through her inferior macula. You can see a little bit of tractional retinal elevation Following macular pucker peel, she looks like this. That scar down at the bottom is where she had a retinotomy or a retinal tear. But her macula looks a lot better, not perfect. This is typically how they look. To answer your question, how does a macula look after a pucker peel? Kind of like this. This is a month or so after her pucker peel. They don't look perfect. And the point of this is that she's visual acuity-wise much better. Inferiorly, the retina is settling down where that traction elevation was. Pre-op, it looked like this. Post-op, it looks like this. In the center of the macula, here's her post-op, here's her pre-op, and her post-op. But patients are not often happy after macular pucker peel. They get better, but they're not perfectly happy.
But her macula was off before.
Macula was off before, so she's never going to be perfectly happy. But she got like 4 opinions on whether or not she should have her pucker peel, and is glad she got it done, but she's still not happy. Her outer segments, if you look to Dr. Kolodner's point, if you look at her outer segments, they're just kind of ratty, because she was macula off, then she had a bad pucker, and they'll probably improve and her vision will get better over the next year, but it's unlikely she'll be happy. Okay, keep watching the macula after your pucker peel. 78-year-old female, pseudophakic, blurry for a year, comes in 20/70, looks like this. Has a macular pucker. I do a macular pucker peel on her. She looks like this post-op day 1. I was so happy with her. I took a post-op day 1 OCT, which I rarely do. I did it to someday show at a conference such as this. Here she is post-op month 2. She is 20/32. She is really happy. I'm really happy. Everyone's happy. Post-op month 6. She developed subretinal fluid for macular degeneration, and this was 2014, so she's been getting 4 years of anti-angiogenic therapy now for her macular degeneration, which occurred after her pucker peel. Don't stop watching your maculas just because you peel them. Okay, we're going to move on to vitreomacular traction and vitreomacular adhesion. Vitreomacular adhesion and vitreomacular traction. What's the difference between vitreomacular adhesion and vitreomacular traction?
The adhesion's just connected, and then the traction's causing spaces.
That's right. Traction causes anatomic and symptomatic, well, anatomic changes is traction, and you have symptomatic and asymptomatic vitreomacular traction. That's the big differentiator as to whether you do anything or not, is whether it's vitreomacular adhesion or asymptomatic vitreomacular traction or symptomatic vitreomacular traction. Oftentimes, patients don't have symptoms, and there are a variety of options for this. You can watch vitreomacular traction, symptomatic or asymptomatic. You can perform Vitrea. Do you guys still do Vitrea? You first years heard of Vitrea? Maybe. Vitrea had a short life. Second years have heard of Vitrea. Third years have heard of Vitrea. Vitrea is an enzyme that was used to lyse vitreoretinal adhesions. There is reasonable evidence that it probably also lysed adhesions between the layers of your retina, at least transiently, which is why it's not widely used. Then you also have the option of pneumatic vitreolysis, which is where you put a gas bubble in the eye. Have you guys seen any presentations with pneumatic vitreolysis? They often say assume the drinking bird position afterwards, where you put in a gas bubble and then bob your head for any one of a variety of specified amounts of time, and it pops off your vitreomacular adhesion. And of course, you also have vitrectomy. These are very gratifying vitrectomies because they're technically very straightforward. You just pop off the vitreous, hope you don't get a macular hole, which you usually don't, and then you're done. Dr. Flynn published a paper following Vitrea's commercialization, which is part of the reason that you haven't heard of Vitrea, that 50% of patients with symptomatic vitreomacular adhesion with observation will resolve spontaneously over the course of several months to a year or so. So observation is not a bad option with these, especially if they're minimally symptomatic. So here's vitreomacular adhesion versus symptomatic vitreomacular traction. 82-year-old male pseudophakic comes in with a complaint of 3 dots in his vision. He's 20/20 plus 2. There's his vitreomacular adhesion. What do you think the appropriate course is in this patient? Do you think his visual complaints are attributable to his vitreomacular adhesion or mild vitreomacular traction?
Probably doesn't have a PVD, right? Based on
Right, he does not have a PVD.
So probably not.
Is his fovea completely normal?
No.
What do you think the right course is here? Observe, right.
Observe,
Do not
yeah.
do a series of Vitrea, pneumatic vitreolysis, then vitrectomy for this guy, because you'll probably not have a 20/20 plus 2i if any of those even go a little bit wrong. Good, so I observed him. Here's another person who comes in, 70-year-old female, blurry central vision, loss of central clarity, 20/40. Symptomatic or asymptomatic vitreomacular traction. What would you do? Well,
Ask her what she wants to do.
Yeah.
First.
Yeah, so we talked about the option of treatment. She elected observation, and she hasn't been back, but there you go. Idiopathic macular holes, again, a vitreomacular adhesion problem. These were originally characterized by Don Gass. Dr. Cohen was a Gass fellow. He had the privilege of working with Don Gass, along with many other esteemed ophthalmologists in the Southeast and in the U.S. throughout. And Dr. Gass defined idiopathic macular holes, and that definition was refined by OCT. What's remarkable is if you read Dr. Gass's papers and then you look at the OCTs, there is incredible concordance between what Dr. Gass thought was the pathophysiology between vitreomacular adhesion and macular hole and what we see on OCT. He was really good at figuring stuff out. Women are most commonly affected, women over 55. There's a 5 to 15% probability of a macular hole in the second eye, which is the most compelling reason to fix the macular hole in the first eye. Symptoms are central distortion, positive Watsky-Allen sign, abnormal foveal reflex, and no posterior vitreous separation unless it's a stage 4 macular hole, which is a macular hole with a PVD. Do you guys know what the Watsky-Allen sign is? Do you guys still do that? Herschel knows. Anyone, any first years know?
We'll do it for fun to see. I mean,
What's
you have
that?
the OCT, so you just do it to confirm or see if you could see it.
Yeah, so a Watsky-Allen sign, you take your slit and you make it into a little tiny bar, and then you take it with your 90 and you put it over the macular hole and you ask the patient if they see a break in the light. And a positive Watsky-Allen sign is that they do see a break in the light. Before you had OCTs, that was a good way to figure out if you had a full thickness macular hole. The pearl here is that this is the single most successful retinal surgery that we do. Not vitreal surgery, because there's actually more successful vitreal surgery, but this is the most successful retinal surgery that we do. We can repair with vitrectomy over 90%, some series say 95 or 97% of stage 2 to 3 macular holes in one surgery. So it's a very good surgery. Patients, again, like macular Parker patients, are often not completely happy afterwards, but you get very good visual acuities, very good anatomic success, very low rates of iatrogenic or postoperative complications. All right, 62-year-old female, blurry vision for 4 or 5 weeks, 20/100. This is what a macular hole looks like on a high magnification color fundus photography. Here's what she looks like a year after successful macular hole repair in our practice. She had vitreous separation, vitreous elevation. You can see the vitreous sticking to that little manhole cover there, and her macula looks pretty good. This is an old case. That's a Stratus time domain OCT.